Dear, dear colleagues, Oliver and Wojciech first reported a case using the novel technique of macular detachment with subretinal BSS injections to treat persistent idiopathic macular hole. Independently, we have been using a similar technique since 2013, which we call the hydraulic centripetal retinal displacement to treat traumatic large macular hole. After vitreous removing, initial LM flap 1 disc diameter was expanded to cover plane location of subretinal injections. To mobilize retinal tissue, 4 subretinal BSS injections were performed at a distance of 2 disc diameter from macular hole edges. Centripetal retinal displacement was performed with backflash instruments, followed by air fluid exchange with a maximum aspiration of subretinal fluid. Surgery was completed by injection SFC or C2F6 and prone position for 5 days. We analyzed the results in 7 patients who was operated on this technique. First case is a man after a tennis ball hitting with a traumatic macular hole 700 microns and choroidal scar with a retinal fixation. LM was peeled after staining with membranbudol. LM was peeled in 2 steps. All vitrectomies was performed with EVO machine by DORC. Subretinal BSS injections were performed in 4 points using subretinal polytip cannula 38 gauge, and centripetal retinal displacement was performed accompanied by dissection retinochoroidal adhesion with 25 gauge needle. Post-op OCT reveal closures of macular hole and release retinochoroidal coalescence with improving BCVA to 0.5. Retinotomycytes were only been visible on autofluorescent image, and we clearly detected post-op centripetal displacements of the temporal retina. Second case is a young lady with a macular hole after a blow from a sparkling wine cork. Also with choroidal scar with the retinal fixation. ILM was peeled by the same technique. During the BSS injections, infusion pressure was temporarily reduced. An additional advantage of this technique is an extrusion of subretinal blood and highly viscous fluid through macular hole during BSS injections. In this case, dissection retinochoroidal adhesion was done with scissors. Post-op OCT also revealed closures of macular hole, dissections retinochoroidal coalescence, and improving visual acuity to 0.2. In case where we failed to close the hole completely, we observed centripetal displacements only in upper temporal direction, where the minimal post-traumatic damage of the retina and pigment epithelium were observed. And we suggest that it would be possible to close the hole completely if we could achieve maximum and uniform displacement of macular tissue from all sides. As a result, complete closure of macular hole was achieved in 85%. Post-op visual acuity was improved in all cases, and there were no intra and post-op complications. That's why we can recommend this technique as additional tools to treat large traumatic macular hole, especially in combination with subretinal fibrous scarring. Thank you for your attention.
Thank you, Ruban. It's a very interesting technique, and my colleague from Ankara is also using this technique. I'm sure Gökhan has something to say, to comment on this, but for myself, I feel it a bit, traumatic. You are inducing 3, 4 small retinotomies, although small, so it's a bit traumatic. So, do you have any problem in those traumatized areas in post-op OCTs?
No. I have shown some OCT picture of the retinotomycytes, absolutely clear and mild healing. Okay. Only on autofluorescent image we have the place of retinotomy. Okay. Maybe if we have some microperimetry, we can detect more clear.
Gökhan?
I believe this is a very nice technique, and I use this technique for persistent large macular holes that they do not. The ILM is previously peeled already, and there's no ILM. So that was the only chance of doing another surgery. This technique is very useful in persistent holes. And Şengül is also right. In the first two cases, I remember, while giving the subretinal fluid, there may be some cracks in the RPE. So the initial fluid filling site must be apart from the foveal edges. So, and I think it will be published. This study will be published soon in ophthalmic surgery and lasers. I have about now 12 cases will be published, I think, but more than 15 cases, and 100% of the cases are closed. And the minimum diameter was about 1,000 microns, and the cases were ranging from 1,000 microns up to 2,500 microns. So, in large persistent holes, I believe this is a good technique. Yes.
Thank
You're
you.
talking about the base or the smallest?
The base.
The base. Okay. Okay.
And
Thank you, Gökhan.
1,000 micron, also the upper part. The
Okay.
In
maximum
our series,
length, yes.
medium macular hole size was 825 microns. It's a medium, mini. It's not basal. It's a minimal macular hole size.
Thank you very much.